Bleeding occurs in our day-to-day life, but they are prevented from being an excessive bleeding by hemostasis. Imbalance between bleeding and clotting can cause disorders. Disorders causing vessel wall abnormalities, reduced or abnormal platelets, and absence or abnormal clotting factors can lead to excessive bleeding. Disorders causing vessel wall abnormalities, excess functioning of abnormal clotting factors, and increased blood viscosity can lead to excessive clotting. Bleeding and clotting disorders can clinically present as petechiae, which are tiny blood leaks from surface capillaries, purpura, which are bleeding under skin from ruptured vessels, ecchymosis or bruises, which are caused by large blood leaks from ruptured capillaries or vessels, swollen and red joints after minor or no trauma due to joint bleeds, bleeding from mucosal surfaces like oral mucosa and conjunctiva, bleeding into spaces, ischemia and gangrene as thrombotic events. These could be due to different underlying disorders such as hemophilia, von Willebrand disease, idiopathic thrombocytopenic purpura, disseminated intravascular coagulation, and chronic liver disease. Patients should not ignore signs like petechiae, purpura, bruises, oral mucosal bleeding, dark colored urine, and consult a doctor to get diagnosed if he has a bleeding or clotting disorder. Therefore, this poster is designed as a public awareness poster including clinical manifestations of bleeding and clotting disorders.
Paralysis. Paralysis is the inability, whether temporary or permanent, to move a part of the body. In almost all cases, paralysis is due to nerve damage. The severity of paralysis varies from one person to another. Partial paralysis have some control of the muscles, whereas complete paralysis does not. There are four main types of paralysis, namely monoplegia, hemiplegia, paraplegia, and quadriplegia.
Monoplegia is a type of paralysis that impacts one limb, such as an arm or a leg on one side of your body. Causes of monoplegia include cerebral palsy, injury to the brain, injury to the spinal cord, or injury to the affected limb. Treatment options are physical therapy and counseling.
Hemiplegia is the paralysis of the muscles of the face, arm, and leg on one side of the body. Causes for hemiplegia include stroke, brain infarctions, and brain trauma. The treatments are physiotherapy and counseling.
Paraplegia refers to paralysis below the waist and usually affects both the legs, the hips, and in some cases the lower abdomen, affecting functions such as sexuality and elimination. Damage to the spinal cord at thoracic and lumbar vertebral levels cause paraplegia, with the commonest cause being road traffic accidents. Other reasons include cord damage due to force, violence, sports, medical injuries, and infections. Exercises such as yoga, weightlifting, seated aerobics, and water aerobics can improve the condition of paraplegic patients.
Quadriplegia refers to paralysis from the neck down, including the trunk, legs, and arms. Causes for quadriplegia are car accidents, falls, violence, sports injuries, medical or surgical injuries. Treatment is physical therapy.
Why am I struggling to breathe? It is shortness of breath. Shortness of breath is known as dyspnea. It can signal an underlying condition. Healthy people generally do not experience it. It can be extremely frightening. You may experience breathlessness, tightness in your chest or chest pain, a sensation of suffocating. This can be acute or chronic.
Acute dyspnea can be caused by anxiety, pneumonia, pregnancy, heart attack or heart failure, carbon monoxide poisoning, blood clots, acute kidney failure, drug poisoning, and low blood pressure.
Chronic dyspnea can be caused by allergies, obesity, asthma, interstitial lung diseases, lung cancers, COPD, high blood pressure, heart conditions, and so on.
Other conditions related to lung function can also trigger shortness of breath. If your shortness of breath is not severe, try the following. Build lung strength with exercise, avoid high elevations, stop smoking, lose weight, avoid allergens and pollutants.
What I should do if my shortness of breath cannot be managed or it is coupled with any of these symptoms, which are chest pain, feeling faint, fever or chills, nausea, swelling in my lower limbs, wheezing or coughing, I have to go to the nearest accident and emergency department, to the nearest hospital immediately.
Good morning, madam. I am Dichen, representing group number 1, and I will be presenting the poster that we created in collaboration for the IAM 1 end semester assignment. Madam, the concept our group adopted is to provide an overview on the topic as a whole, and the topic is shock. Shock is a systemic state of low tissue perfusion that is inadequate for normal cellular respiration, and this results in generalized hypoxia of tissues and cells, which is the hallmark feature of shock. Shock is categorized into several types based on the mechanism or pathophysiology. The first type is hypovolemic shock. Hypovolemic shock occurs due to reduced circulatory blood volume, and it is the commonest type of shock. Hypovolemic shock can be hemorrhagic or non-hemorrhagic. Hemorrhagic hypovolemic shock is due to excessive loss of circulatory blood volume. It can either be internal bleeding or external bleeding. Internal bleeding means bleeding into the body cavities or within the internal organs. External hemorrhagic hypovolemic shock occurs more commonly due to trauma such as road traffic accident. Non-hemorrhagic shock is due to loss of fluid from the body, and the common causes include reduced fluid intake in conditions like dehydration, or in conditions which cause loss of fluid from the body such as vomiting and diarrhea. The second type of shock is cardiogenic shock, which is due to failure of the heart to pump blood to tissues. Next is the obstructive shock, which is due to inadequate cardiac output due to obstruction to blood flow in the lungs or the circulatory system. Distributive shock. It occurs due to inadequate supply to increase vascular capacitance. It is associated with extensive vasodilatation of blood vessels and hypotension. It can either be anaphylactic shock following inflammatory reaction to allergens, septic shock caused by toxins, and neurogenic shock caused by spinal cord damage. Endocrine shock can occur due to adrenal insufficiency or in conditions such as hypothyroidism and hyperthyroidism, in which patients do not respond effectively to catecholamines released by adrenal medulla. How can we diagnose shock? There are several features and clinical signs which helps us diagnose shock. Systolic blood pressure below 90 millimeters per mercury, cerebral hypoperfusion resulting in CNS symptoms like confusion and restlessness, decreased renal blood flow causing oliguria, and decreased peripheral blood flow which delays capillary refill. When a shock sets in, body activates compensatory mechanism to bring back body's physiology to normal homeostasis. The first step is the reversible phase, in which the normal compensatory mechanisms will cause full recovery and it occurs due to negative feedback control mechanisms of circulation. The main important effect is due to increased sympathetic output, which causes generalized vasoconstriction, which means constriction of both veins and arteries. This causes diversion of blood from non-essential organs such as skin, gastrointestinal tract, and skeletal muscles to essential organs like the brain, kidney, and heart, which increases venous return. Arterial constriction increases total peripheral resistance, which increases the blood pressure. The humoral response is mainly mediated through renin-angiotensin-aldosterone system, which is a very strong and an effective compensatory mechanism. After the shock has progressed to a certain stage, there is no longer any response to transfusion or any sort of therapy. In this, the patient has now progressed into irreversible stage, and any sort of therapy cannot bring back the patient back to life and eventually causes death. There is progressive fall in blood pressure, multi-organ failure, disseminated intravascular coagulation, and death. Shock is an emergency condition, a medical emergency. It requires immediate treatment and it can get worse very rapidly. Therefore, prompt treatment is necessary. We need to manage the emergency, determine the underlying cause, and definitive management and support should be given. Thank you.
Acid-base disturbances. Normal pH of blood in humans ranges from 7.35 to 7.45. In a normal arterial blood gas analysis, partial pressure of carbon dioxide varies between 36 to 46 mercury millimeters. Bicarbonate levels varies between 22 to 26 millimoles per liter. When the blood pH falls below 7.35, it's called acidosis. When the blood pH rises above 7.45, it's called alkalosis. There are 4 types of acid-base disorders: respiratory acidosis, respiratory alkalosis, metabolic acidosis, and metabolic alkalosis. Acid-base disorders are primarily either respiratory or metabolic. Respiratory if the primary disturbance involves carbon dioxide. Metabolic if the primary disturbance involves bicarbonate.
Respiratory acidosis. Respiratory acidosis is a fall in pH because of a rise in carbon dioxide partial pressure in blood. It occurs broadly due to hypoventilation and VQ mismatch. Kidneys compensate the respiratory acidosis by excreting acid and retaining bicarbonate. Respiratory alkalosis. Respiratory alkalosis is a rise in pH due to lowering of carbon dioxide partial pressure in blood. It occurs due to excessive carbon dioxide washout by hyperventilation. Kidneys compensate respiratory alkalosis by excreting more bicarbonate.
Metabolic acidosis. This is a fall in pH due to a source other than carbon dioxide. This means either a gain of acid or loss of bicarbonate. Causes for metabolic acidosis include diabetic ketoacidosis, renal failure, etc. This is compensated via the respiratory route. Metabolic alkalosis. This is a rise in pH due to a non-respiratory route, which means a gain of bicarbonate or loss of acid. Causes for this include vomiting of gastric content, administration of sodium bicarbonate, etc. This is also compensated by the respiratory route.
Edema. Edema is defined as abnormal and excess fluid accumulation in the interstitial compartment due to
an imbalance in fluid homeostasis. Edema either caused by decreased absorption or increased secretion of fluid into the interstitium. Edema formation occurs when there is an increase in capillary hydrostatic pressure, an increase in capillary permeability, a decrease in plasma oncotic pressure, or due to lymphatic obstruction. An increase in capillary hydrostatic pressure may be secondarily due to heart failure or a venous obstruction or compression or renal failure. An increase in capillary permeability may be seen after infection or inflammation or severe sepsis. A decrease in plasma oncotic pressure can be seen in nephrotic syndrome, liver failure, or severe malnutrition. Lymphatic obstruction can be seen in residual mastectomy for breast cancer, pressure on main lymph ducts, occlusion of lymphatic by malignant cells, or inflammation of lymphatics. Types of edema. Edema can be classified as general edema and local edema. General edema is due to cardiac failure, renal failure, or hepatic disease. Localized edema is lymphedema, inflammation, or lymphatic edema. Edema can also be classified as pitting edema and non-pitting edema. In pitting edema, it feels firm and does not form an indentation. In non-pitting edema, indentation appears. Edematous fluid may be transudate or exudate. In exudate, every component is excess in there.
Hello, I'm from group 13 and I'm going to present about oliguria. The normal urine output is the amount of urine excreted per 24 hours, and in a normal adult it is from 800 to 2000 milliliters per day or 0.5 to 1.5 milliliters per kilogram per hour. So, oliguria can be defined as the urine output less than 1 milliliters per kilogram per hour in infants, less than 0.5 milliliters per kilogram per hour in children, less than 400 milliliters per day in adults. Let's concentrate about the causes of the oliguria. This can be divided into three parts: pre-renal, intrarenal, and post-renal causes. In pre-renal failure, there is a structurally normal kidney, but oliguria is functional response of the kidneys to hypoperfusion. Pre-renal causes could be either euvolemic hypoperfusion like cardiogenic shock, septic shock, and vascular occlusion, or hypovolemic hypoperfusion like dehydration, diarrhea, vomiting, and hemorrhage. Next, the intrinsic renal failure is associated with structurally damaged kidney. Causes of the intrarenal failure are acute tubular necrosis due to prolonged ischemia, drugs or toxin, vasculitis, primary glomerular diseases, or intestinal nephritis due to drugs or toxins. Then the last one, the post-renal failure, is due to mechanical or functional obstruction of the flow of the urine. This can be due to strictures, retroperitoneal fibrosis, renal calculi, blood clots, or bladder outlet obstructions like benign prostatic hyperplasia and catheter blockage. When we look at the investigations of the oliguria, we can do it by investigating either blood or urine. In urine analysis, there are microscopic, macroscopic, chemical and physical analysis. The color of the urine, clearness and the odor of the urine can be investigated as microscopic analysis, while urine specific gravity and volume can be measured as physical analysis. The chemical analysis include pH, protein, bilirubin, creatine and reducing substances. In macroscopic analysis, presence of red blood cells, white blood cells, crystals and cast are checked. In serum analysis, we looked at the blood urea, creatine, electrolytes, especially the potassium, and arterial blood gas analysis. Management of the oliguria depend on the site and the cause of the oliguria. During management, fluid status, electrolyte abnormalities, especially the hyperkalemia, acid-base balance, and hypertension management is essential. If there is any structural obstruction, it is important to release of such. If untreated, oliguria can be progressed into life-threatening conditions. Thank you.
Hello everyone, this is Group 5 and our poster is on jaundice. What is jaundice? It is a condition in which the skin and the sclera of the eyes become yellow, the urine darkens and the color of stool becomes lighter than normal. Why do we call it jaundice? Well, the old French called it jaune, which meant yellow, and then it derived into Middle English as jaundice, and now it is called jaundice. Jaundice is also known as icterus, as how the Greeks called it, and the Latin use of the term also denoted a yellow-green bird, the sight of which was thought to cure jaundice. So how do you know if you've got jaundice? You have 4 common symptoms. 1. Pruritus, itching of the skin. 2. Dark urine, especially tea-colored. 3. Steatorrhea, pale, fatty, foul-smelling stools which are hard to flush. And 4. Yellowish discoloration of the skin and mucous membrane, particularly the sclera. So how does your body turn yellow in jaundice? It is because of bilirubin. So what is bilirubin? Bilirubin is a breakdown product of heme. Heme is a part of hemoglobin found in red blood cells. So initially when heme is broken down, it forms biliverdin, which is then converted to unconjugated bilirubin and then transported to the liver to form conjugated bilirubin and finally excreted in bile into the gastrointestinal tract. What are the types of jaundice? There are mainly 3. 2 in adults, non-obstructive jaundice and obstructive jaundice, and finally neonatal jaundice. What causes jaundice in adults? Well, there are 3 major types: prehepatic, hepatic and posthepatic. Let's take an example for each. Prehepatic jaundice can be caused by hemolytic anemia. Hepatic jaundice can be caused by alcoholic liver disease, and posthepatic jaundice can be caused due to gallstone. How do you find which type of jaundice an adult patient has? In the patient's blood, you check for the type of elevated bilirubin as well as the serum bile salt level. In the urine, you check for urine bilirubin and urine urobilinogen levels. To check whether the cause is hepatic or not, you conduct a liver function test to assess the serum alkaline phosphatase levels or conduct a coagulation test. Or simply, you look for the color of the stool, the color of the urine, or check to see whether the patient has pruritus or not to come to a conclusion. Now, if you are interested to know why the urine turns brown in jaundice, or why in a normal person the urine is yellow and their stools are brown, check this comic sketch by Art Biotics. What causes jaundice in infants? Physiologic neonatal jaundice is caused due to the low activity or deficiency in neonatal liver conjugating enzymes. Breastfeeding neonatal jaundice, on the other hand, is caused due to insufficient breast milk intake. And finally, breast milk neonatal jaundice is caused due to certain metabolites present in the breast milk which go and inhibit or reduce the activity of the conjugating neonatal liver enzyme. On a surgical perspective, obstructive jaundice is of prime importance. How do you know where the obstruction is? Well, you conduct an imaging study. What are these imaging studies? Ultrasound scans, CT scans, or special scans such as endoscopic retrograde cholangiopancreatography or percutaneous transhepatic cholangiography. How is jaundice treated? In adults, jaundice itself usually isn't treated, but the underlying conditions causing it are treated. However, supportive care is given to the patient via the usage of analgesics, antipyretics, or even antihistamine. How are icteric infants treated? Well, there are 4 treatment methods. 1. Phototherapy. 2. Exchange transfusion. 3. Fluid therapy. And 4. Intravenous immune globulin therapy. Finally, how fatal is neonatal jaundice? If neonatal jaundice is not screened for, left untreated, or undiagnosed, it could lead to devastating consequences, 2 of which are erythroblastosis fetalis and kernicterus.
Different stressors like trauma can affect homeostasis to various extents. These result in various changes, and these changes are called metabolic responses to trauma. Trauma is associated with pain, tissue damage, hypovolemia, hypercapnia, and etc. Inflammation and response to infection and tissue damage results in production of cytokines. These cytokines can have many systemic effects. Interleukin-1 results in fever. Interleukin-6 produce acute phase proteins which are responsible for the acute phase reaction, which comprises systemic manifestations in both acute and chronic inflammation. Interleukin-6 can also affect ACTH release. Signals of pain, tissue damage, and hypovolemia lead to brain through somatic and visceral nerves. These signals result in activation of sympathetic nervous system and release of adrenaline and noradrenaline. These catecholamines result in tachycardia, increase of oxygen consumption, which ensure adequate oxygen and nutrient supply, bronchodilation, and decrease of GI motility. They also result in inhibition of insulin secretion while stimulation of glucagon release from the pancreas. Glucagon involves in breakdown of glycogen, gluconeogenesis, lipolysis, and breakdown of proteins. And adrenaline and noradrenaline also involves in release of renin, which activates renin-angiotensin-aldosterone system that ultimately results in aldosterone release. Aldosterone involves in conservation of water and sodium and also promotes potassium excretion from the body. Same signals of pain, tissue damage along with cytokines results in release of different hypothalamic hormones, and these hormones affect secretion of pituitary hormones. Corticotrophin releasing hormones secreted from hypothalamus stimulates pituitary to secrete ACTH, which stimulate adrenal glands to secrete cortisol. Cortisol is one of the main catabolic hormones and involves in glycogen and protein breakdown and gluconeogenesis. Growth hormone releasing hormone released by hypothalamus stimulates secretion of growth hormone from pituitary. Growth hormone has almost similar functions of glucagon as discussed earlier. Posterior pituitary gland also secretes ADH, which increases water reabsorption and facilitate water conservation. So to summarize, Three systems mainly contribute in metabolic responses to trauma. These systems are sympathetic nervous system, neuroendocrine system, and the immune system. Activation of these systems result in breakdown of carbohydrates, lipids, and proteins, and also inhibition of anabolism and conservation of water and sodium. Inflammation also helps in tissue repair and control of the infection.
Group 3 under chest pain topic. Chest pain is the most frequent reason people come to the emergency department. Its numerous causes range from benign to life-threatening. Our main purpose of making this poster is to give some idea about causes of chest pain and to determine who is having or is at risk of having an emergent problem. Before moving into causes of chest pain, to analyze any pain and cause of pain better, applying mnemonic Socrates will efficient. Socrates, site. Where in the chest are the symptoms located, like center, right or left-sided, epigastric, interscapular? Onset. How did this pain start? Acute, subacute, chronic? And character. What type of pain? Like tightening, pricking, heaviness, squeezing, burning, tearing, or ripping? Radiation. Does this pain radiate anywhere? Like to neck, to left upper limb, right upper limb, epigastrium, jaw, back? Association. Are there any other symptoms? Difficulty in breathing, sweating, nausea, vomiting, cough, or faintness? Time course. How long have been having these symptoms? How long last they? Like persist, episodic, exacerbating or relieving factors. Does any activity make symptoms worse or better? Like exertion, coughing, deep breathing, movement of chest, eating or drinking, change of posture. Then severity, how severe the chest pain is, mild, moderate, or severe. If we look at causes of chest pain, we can categorize them as cardiovascular, gastrointestinal, pulmonary, musculoskeletal, neurological, and psychogenic.
Cardiovascular causes of chest pain. Angina is one of the most commonest cause of chest pain. Patients are complaining about pain behind the sternum known as retrosternal chest pain. Onset is acute or subacute. Pain can radiate to neck, jaw, shoulders, arms and epigastrium and also associate with breathless feeling. Myocardial infarction, more severe and latent state called heart attack. Patients may present with acute retrosternal chest pain. Radiation and characters of chest pain are similar to angina, but it may associated with nausea, vomiting and sweating. The next cardiovascular cause of chest pain is rather uncommon, rare condition, acute aortic dissection. Patients present with very severe acute retrosternal pain which felt as tearing or ripping pain radiate to the back between shoulders. Pain lasts longer and acute aortic dissection may associated with poorly controlled hypertension. Pericarditis, which is inflammation of pericardium. In this, patients may present with sharp and severe retrosternal or left-sided chest pain.
If we look at what are the musculoskeletal causes of chest pain, one is chest wall injuries. Then a rather common condition which is costochondritis. Here, the patient may present with local tenderness and painful areas in chest, can associated with viral infections. Sharp and severe pain in the sternal area, and pain can exacerbated by movement of the chest wall. Other cause of musculoskeletal chest pain is maybe due to secondary tumors of the ribs.
The respiratory causes of chest pain. Pneumonia is a condition which patients come with fever, sometimes productive cough and difficulty in breathing. It causes unilateral and localized pleuritic pain. Then, a condition known as pneumothorax, which is collection of air in pleural cavity, and also pulmonary embolism can cause chest pain.
Gastrointestinal causes of chest pain are reflux esophagitis, a very common problem in clinical practice, which is inflammation of lower part of esophagus due to gastric acid. Pain is felt as burning in the substernal or epigastric region, which radiate to neck and can associated with nausea, vomiting, regurgitation. Pain can worsen by postprandial recumbency and relieved by antacids. Peptic ulcer disease. Patient may present with pain felt as burning sensation in substernal or epigastric region, which may radiate to the back. Can be associated with vomiting, loss of appetite, presence of causative factors, and pain can be relieved by food or antacid. Then an uncommon condition, esophageal spasm. Sharp and severe pain can be felt as burning or tightening in restosternal region in an intermittent manner, which may radiate to the neck. Chest pain can be associated with dysphagia, regurgitation, and sensation that an object is trapped in the throat. Esophageal spasm can closely mimic angina.
Next, the neurological causes of chest pain. Prolapsed intervertebral discs. Here, nerves get compressed and present with pain radiating along dermatomes. Herpes zoster is a common condition following chickenpox. It can cause unilateral and localized chest pain.
Lastly, psychogenical chest pain can occur due to conditions like anxiety, depression. Patient may present with non-specific site of pain and variable severity and character of pain, may associated with other symptoms of anxiety and depression. So these are the causes of chest pain and their categories. Thank you.
Our team's topic is abnormal uterine bleeding. In a normal woman, normal menstruation occurs regularly as a 28-day cycle. In one cycle, about 25 to 80 milliliters of blood is flown out in normal menstruation. And if the cycle is irregular or the amount of blood flow is unusually high, then it is called an abnormal uterine bleeding. When we see the classification, the causes of abnormal uterine bleeding, there's a classification called palm coin classification based on the pathology of the bleeding. In the palm coin classification, there are two main entities called, first one is the structural entities related to uterus and cervix, then the other one is the non-structural entities. There are four causes for the structural entities. First one is the polyp. Polyps are epithelial proliferations, mostly benign. They can be occur in endometrial or endocervical, and most commonly they are asymptomatic. The second one of the structural causes are the adenomyosis. This is the ectopic presence of endometrial glands and stroma in the myometrium. And the third one is the leiomyomas, or most commonly called as fibroids. This is a quite common phenomenon. What happens is vascularized benign tumors may occur in the uterus. And the most common cause for abnormal uterine bleeding are the submucous fibroids. And the last one in the structural causes are the malignancy or hyperplasia. Hyperplasia is the uncontrolled overgrowth of endometrium tissue, and if this persists for a longer period, that can become a cancer, uterine cancer. And next, the next part is the non-structural entities like coagulopathies and ovular dysfunction. The first one under this category is the coagulopathies. Coagulopathies is the problems in the normal coagulation pathway. For an example, von Willebrand factor disease. And the second one is ovulatory dysfunction. This ovulatory dysfunctions mostly happens in the extremes of reproductive age. For an example, in adolescence, where the HPO axis is immature, and the perimenopause women. And mental stress, obesity, weight loss, and polycystic ovary syndrome are some of the predisposing factors for ovulatory dysfunction. And next cause is endometrial causes. In here, local endometrial hemostasis is lost due to local production of vasodilators and increased lytic substance production and endometrial inflammation and infection. The fourth one under non-structural entities is the iatrogenic causes. This is the bleeding due to factors that are artificially created. For an example, intrauterine contraceptive devices and use of anticoagulants like warfarin for another medical condition, and use of antibiotics and anticonvulsants. The final one is the non-classified entities, for an example like chronic endometriosis and atriovenous malformations. Thank you.
In this poster, we talk about seizures, convulsions, and epilepsy.
Seizures are brief disturbance of brain function due to abnormal and excessive discharge of cerebral neurons. The reason for the uncontrolled action potential generation may be anything that interferes with the normal physiology of the brain. For example, cerebral trauma or changes in the extracellular fluid composition. Convulsions are seizures that are mainly a motor disturbance with uncontrolled and involuntary motor activity. Epilepsy is a condition characterized by occurrence of 2 or more unprovoked seizures as a result of a brain disorder. In about 80% of epilepsies, the exact cause is unknown, whereas the rest occur secondary to a brain injury like neurodegenerative disease, cerebral tumor, and so on. Seizures are mainly classified into two as generalized onset seizures and focal onset seizures. Generalized onset seizures show a symmetrical onset of abnormal impulse discharge from both cerebral hemispheres and always present with loss of consciousness. They have no prior warning. On the other hand, focal onset and partial seizures originate in a small group of dysfunctional neurons in one of the cerebral hemispheres. They may proceed by an aura and may even progress into a generalized seizure. Partial seizures are categorized as follows: simple partial seizures where there is no loss of awareness, and complex partial seizures where the individual shows a loss of awareness. As mentioned here, focal onset seizures may be preceded by an aura. So, what exactly is an epileptic aura? It is a simple partial seizure, often sensory, that gives warning of an oncoming complex partial seizure. Auras typically originated from temporal, frontal, parietal, occipital lobes. Let us look at some examples for epileptic auras that can help with interfering the origin of seizure. If the origin is in the temporal lobe, the individual may have auditory hallucinations since the primary auditory cortex is located here. They may also give vertiginous feature or fear that can be mistaken for a panic attack. The frontal lobe contains the motor cortex and the motor speech area. Therefore, we may see clinical manifestations like abnormal body posturing, repetitive movements, aphasia, or dysphasia if the seizure originates from the frontal lobe. The occipital lobe houses the visual cortex. So, if the seizure originates from here, the individual may have visual hallucinations. The primary somatosensory cortex is in the parietal lobe. If it is the origin of the seizure, the individual may feel altered contralateral sensations as mentioned in the poster. Finally, we touch upon the management of seizure, which involves two parts, that is, the acute management and in the case of epilepsy patient, the long-term management. It mainly focuses on minimizing harm via proper positioning of the body and administering appropriate anti-epileptic drugs while also addressing the problems the individual may face in day-to-day life. Thank you.
We are Group 8 and our poster topic is on headaches. What is headache? Headache is the symptom of pain anywhere in the region of the head or neck. The WHO reports that almost half of all adults worldwide will experience a headache in any given year. So this will cause significant suffering and also an economical loss. So it is a very important topic in medical career. There are lots of pain-sensitive structures in the head and neck region. So the key to proper management of headache is to make an accurate diagnosis. So we have to recognize the features of dangerous headaches, and also we should know how to rule out those features. So when considering about headaches, we should know about the pain-sensitive structures in the head. We do classify those structures into three main categories. Those are extracranial structures, nerves, and intracranial structures. The extracranial structures which are sensitive to pain around the head and neck region are skin, subcutaneous tissue, muscles, periosteum of the skull, mucosa, extracranial arteries, delicate structures of the eye, ear, nasal cavities, and sinuses. What are the nerves which are pain-sensitive structures in the head? Those are trigeminal nerve, facial nerve, glossopharyngeal nerve, vagus nerve, and upper three cervical roots. When considering the intracranial structures which are pain-sensitive, these are venous sinuses and afferent veins, arteries of the dura mater and pia arachnoid, arteries of the base of the brain and their major branches, and parts of the dura mater near the large vessels. So a headache can be happened due to a stimulation of primary nociceptors, and also it can be due to lesions in pain-producing pathways of peripheral nerve system and central nervous system. So when considering the mechanism of occurring a headache, it can be due to distension, traction, or dilatation of intracranial or extracranial arteries, and also it can be due to traction or displacement of large intracranial veins or their envelope. Also, these headaches can be happened due to meningeal irritation due to underlying inflammation, like meningitis. If there is a compression, traction, or inflammation of the cranial or spinal nerves, headache can be happened. If there is a spasm, inflammation, and trauma to cranial and cervical muscles, and also headaches can be happened. There's a classification of headaches according to the IHS. Those are the primary headaches, the secondary headaches, and cranial neuralgias, central and primary facial pain, and other headaches. In this poster, we do consider about the primary headaches. Primary headaches is a headache that is not caused by another underlying disease, trauma, or medical condition. This type of headaches count for 90% of cases. Secondary headaches are caused by exogenous disorders. So how do we classify these headaches into primary and secondary categories? So at first we should do a physical examination, and we should get a proper history about the headache characteristic, location and radiation, quality, alleviating and exacerbating features, associated symptoms, constitutional symptoms, and also we should know about the patient's other disease conditions like diabetic mellitus, hyperlipidemia, smoking, and also about hypertension. So there are some procedures to approach a patient with headache. We should exclude red flags in order to classify a headache as a primary headache. If we do find some red flags, it is not a primary headache anymore. Then we consider that headache as a secondary headache. So what are these red flags? This famous mnemonic called SNOOP. So SNOOP, systemic symptoms like fever, weight loss, we should consider about these factors, and also we should consider about secondary risk factors like cancer, HIV, and also we should know the neurologic symptoms or abnormal signs of the patient. We should ask from the patient about the onset of the headache, whether it is a new onset or chronic headache, and also we should know how old the patient is, because the patients above 50 years there are new headaches. And also we should ask from the patient whether the headache increases when he is in upright position.
that is the positional component. And also we should know about the provocative factors, which are whether the headache is precipitated by coughing, exercise, and also when he is involved in a sexual activity. We will turn on to our poster now. So our poster is mainly on the primary headaches. We do classify primary headaches into 4 categories. Those are migraine, tension type headache, cluster headache, and trigeminal neuralgias. When considering about migraine, this is a very common condition. The clinical features of migraine are simmering central stoma, and also this is a pulsatile headache. You will get nausea and vomiting, and also these patients usually have phonophobia and photophobia. This headache is triggered by certain factors. Those are fasting, sleep deprivation, menses, and also some foods like chocolates, nuts, cheese, caffeine. How do we treat a patient with migraine? We should give NSAIDs for the acute pains as an analgesic, and also we give triptans, antiemetics, and steroids in order to relieve the pain. The prophylaxis contains beta blockers, calcium channel blockers, anti-epileptic drugs, and also the antidepressants. Our second category is tension type headache. The clinical features are bilateral non-pulsatile pain, usually preceded by tight feeling high in the neck. This is stimulated by stresses like upset. So what are the treatments available for tension type headaches? We should first recognize if this patient is having a comorbid illness such as migraine, anxiety, and depression. For episodic tension headaches, we do give NSAIDs as analgesics. For chronic tension headaches, we do give a prophylaxis containing amitriptyline, and also we can give psychotherapy, and we should modify the lifestyle of the patient. The lifestyle modifications are important. The other type of the headache is primary headaches is cluster headache. The cluster headache, the clinical features are the patient will experience watery eye, drooping eyelid, runny nose, unilateral stabbing type pain around the eye. The treatments is mainly a symptomatic treatment. We should give oxygen, triptans, anesthetics, alkaloids, and also the prophylaxis contains calcium channel blockers, mood destabilizers, and also anticonvulsants. The other type of primary headaches is trigeminal neuralgia. Usually, the patients with this trigeminal neuralgia go for dentists, assuming this is because of this pain is because of their bad teeth. This pain is arising from trigeminal nerve. The clinical features are the right facial pain, sharp shooting pain radiating over right cheek. This is exacerbated by chewing, brushing teeth, and also by shaving. So, patients assume that this is due to their toothache. So, they usually visit dentists. The treatments are the mood stabilizers like carbamazepine and also gabapentin. So that ends up our presentation and the poster on the primary headaches. Thank you.
Hello everybody. We are the students of Group 2. The topic for our poster is fever. The main aim of our presentation is to acknowledge the public about fever, its causes, consequences, and the management of fever. Fever, which is also known as pyrexia, is an unpleasant sensation to the individual. It is one of the most oldest clinical indicators for many underlying diseases. Fever is an abnormality in body temperature regulation when the hypothalamic set point is elevated. Normal body temperature is maintained at 37 degrees Celsius. When the body temperature rises above 38 degrees Celsius or 100.4 Fahrenheit, we identify it as fever. Fever can arise due to infections from exogenous or endogenous pyrogens. Some of the common infections are upper respiratory tract infections, gastrointestinal tract infections, and urinogenital tract infections. Fever may also be due to patient's health and occupation. Any recent invasive procedures may be an underlying cause for fever. Fever may originate from diseased vectors such as mosquitoes and ticks. Pyrogens from contaminated food and water are also causes to produce fever. Temperatures greater than 38 degrees Celsius, chills and shivering, body aches, flushed or red face, sweating, and fast heart rate are the most common clinical symptoms presented with fever. I would like to invite one of my group mates to continue with the presentation.
The major consequences of fever can be presented as follows. When the body temperature is increased, proteins can denature. Also, fever leads to releasing of inflammatory cytokines, which leads to activation of inflammatory cascade. This results in disseminated intravenous coagulation, ultimately leading to organ system dysfunction. So, due to above consequences, management of fever is a highly important task. Paracetamol, which is an antipyretic, can be given while monitoring the temperature of the patient. Rehydration of the patient can be done by giving clear and nutritious fluid. Tepid sponging can be carried out to reduce the body temperature of the patient. To reduce the fever, the underlying cause can be treated. To diagnose the underlying cause, we can do full blood count and inflammatory marker investigations. So, we hope that our message through this poster is clear and understandable. Thank you.
Syncope. Syncope, or otherwise fainting, is when a person loses consciousness and muscle strength. The characteristics of syncope include regaining consciousness quickly without a long-lasting duration, followed with spontaneous recovery. It is also stated that there is no resuscitation needed. There are three major types of syncope. They include reflex syncope, cardiac syncope, and neurocardiogenic syncope. The commonest causes for syncope are as follows. It can be a sudden drop in blood pressure, a serious medical disorder, any drastic hormonal fluctuation, or any benign condition. The usual symptoms associated with a syncope: feeling lightheaded or weak when standing, falling for no reason at all, vision changes, and blacking out. The treatment options available depend upon the underlying cause, but they can include the following: taking appropriate medications according to the compliance, avoiding situations that cause episodes, undergoing biofeedback training, treating hormonal imbalance.
Abdominal pain. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage. We can categorize pain according to the duration as acute pain and chronic pain. Acute pain is a pain which is sudden onset and lasts for only a short period of time, and it is well localized, mostly due to somatic causes. And the chronic pain, which is a persistent pain, persists for more than 3 months, and it is poorly localized, most probably due to visceral organs. And also, according to the causation of the pain, The pain can be further categorized as neuropathic pain, nosospastic, and nociceptive pain. In the abdominal pain, the causes could be due to abdominal wall herniations, inflammation, trauma, and ischemic diseases, and pain coming from spine and nerves, as in cutaneous nerve entrapment and in spinal cord tumors. Or it could be due to psychogenic pain, and also in visceral pain due to intra-abdominal organs like in acute appendicitis, cholangitis, and inflammatory bowel diseases. And also the pain could, within the abdominal pain, could be due to extra-abdominal organs like pneumothorax and myocardial infarctions. Pain due to retroperitoneal organs are like in kidneys, inflammation over kidneys, adrenal gland, pancreas, like retroperitoneal organs. So, somatic pain is well localized and visceral pain is poorly localized. The referred pain is that the pain felt in a part of the body other than its actual source. So gallstones, cholecystitis, stomach or duodenal ulcers, and hepatitis, rising pain can be felt within right hypochondriac region. And appendicitis, inflammatory bowel diseases, constipation, and pelvic pain is referred in right inguinal region, while in umbilical hernia, early appendicitis, stomach ulcers, inflammatory bowel diseases, and pancreatitis could be referred within the circumumbilical region. In the right and left lumbar region referred pains due to kidney stones, kidney infections, inflammatory bowel disease, and constipation. So mostly that the causations arise from foregut. The pain is referred within the epigastric region, and the causations within the midgut, the pain referred within circumumbilical region, and if it is a disease associated with hindgut, then the pain is referred within the suprapubic region. So the pathologies behind the pain could be a trauma, inflammation, neurogenic pain, neoplasia, ischemia, or obstruction. The colic pain is pain that due to hollow organs vigorously contract their muscular wall to expel the causation of obstruction. So colic pains are the renal colics, biliary colics, intestinal colics, etc. So the renal colic radiates from line to groin. Biliary colic is first referred within right hypochondriac region, and then it radiates towards back through the thorax. Acute appendicitis referred early within the circumumbilical region, and then it radiates towards the right inguinal region. Acute pancreatitis, the pain is referred within circumumbilical region, and then it radiates towards directly towards background. On specific abdominal examination, inspection should be done to observe the shape and movements, scars, distension, bruises, striae, and pigmentation. And percussion should be done to get resonant over most of the abdomen if it is normal. Auscultation is done to detect bowel sounds, rubs over liver and spleen. And palpation also should be done.